So when we're talking about a surge in Mpox cases across the African continent this year, what are we looking at compared with last year? How much more serious is it?
Yeah, thank you. It's actually quite different because what we've seen just over the past few months is that we're actually dealing with an emergent new variant of Mpox, which is looking very different than the original strain that we know. So we actually should think about Mpox as three different strains now. We've got the original Clade 1, we call it, that was circulating around Africa and has been there for decades. We had the monkeypox, or Mpox as we're obviously now calling it, in Europe, 2022, which is called Clade 2. And this newly identified strain that's been called Clade 1b, which is emerging, which we should perhaps focus our attention on because this is what is looking of most concern. But Clade 1 and Clade 1b are circulating together, but probably in slightly different regions.
And what do we know about Clade 1b? How is it passed on?
So the data is still being collected and analysed. It's a very difficult place to work. I think this is the most important thing to make clear first. It's emerged in this area, which is the border between DRC, Rwanda, Burundi and Uganda. And the first cases were in a small mining town in a very difficult place to reach in South Kivu in DRC. And so it's been very difficult to have a research response to gather this disease characterisation data that we needed. But the teams there, the local public health government research team, are doing an incredible job. So the information I'll explain comes from that research, they're releasing and publishing as much as they go, but we're very much still in the process of capturing and analysing this data. So what we do know so far is that unlike Clade 1, which is passed from generally somebody bringing some bushmeat into the family and that meat being infected and it infecting the family and it being passed around within the household, what we're seeing with Clade 1b is this is emerging from often sexual transmission, heterosexual sex. It's been associated with bars, with sex workers and the trade that happens around this mining town. But we are also seeing person-to-person transmission outside households, mother to child, carer to child. And so very different really from this, what we call zoonotic association we've seen with Clade 1, which is more around this bushmeat contamination in households. So very different transmission and also quite different presentation of the way the disease is appearing and behaving in the people infected.
And it seems to be very serious as well. So this is a much more serious disease than, say, the Mpox that was seen in Europe.
Yes, the Mpox that we saw in Europe that was associated, it was very close contact transmission. So we saw this in the homosexual community mainly, and quite a low mortality rate. What we're seeing with this Clade 1b is, and this is data not yet fully analysed, as I say, but it's obvious from what's been seeing in these communities, is it's looking like something in the order of 10% mortality in children and 5% in adults. The problem we have, though, is we're obviously just seeing the severe cases because already this is associated with stigma. And so we're only seeing the cases and can measure the cases that are coming in. And so my concern is the number of cases that are less severe or people are hiding, it's highly stigmatised or they're not even aware, and we don't really know how much transmission there is in less severe cases. So we don't really know the true burden of this disease yet. And so it's difficult to make a guess on the mortality because they're the severe cases, but also the perhaps bigger impact of being more cases in the community than we know about.
Now, when we spoke about this strain on Health Check a little while ago, just over a month ago, the message then was very much that if something wasn't done, we could see further spread. Yeah. And is that what we're now seeing now? Yes. That's in 10 different countries in Africa?
Yeah, absolutely. Well, yes, we did. We spoke about this a few weeks ago quite widely, and we're worrying around this wider spread. And of course, this is what we're seeing. The 10 countries in Africa, some of them, of course, have got Clade 1 that they're reporting, but we are seeing more reported cases of Clade 1b, which is really concerning. So in Uganda and Kenya, Burundi, Rwanda and DRC, we're now seeing reports of Clade 1b. So that's very significant and is definitely a change from the last few weeks.
And why is it harder to handle this year than last year's Mpox outbreak? Is this because of this new type?
Yes, definitely. So across these African nations, this is this is circulating in areas of extreme poverty that are very difficult to reach. I've heard this described several times over the last few months as like the early days of HIV, because we're seeing this transmission in mining towns and on trucking routes, the sexual transmission, but obviously this wider person-to-person transmission as well. When the disease when we first sequenced clade 1b and realised what was happening, this was also in the middle of the rainy season, where this region, South Kivu and DRC, was actually very hard to reach, and the roads were almost impassable, certainly into DRC, but even difficult moving into Rwanda and the neighbouring countries. It's the dry season now. The roads are much easier to travel across. It's the long holidays, and so there's a really heightened level of concern. But the real main difference is obviously this difference in transmission. It seems to be that it's much more easier to pass on than the original clade 1, which is more concerned with this association with zoonotic infection and infected meat. This is the human reservoir and being passed person to person. And so the combination of the change in seasons, the fact that it's in these highly vulnerable communities and very difficult to reach settings, and we have so many unknowns still in terms of the level of less severe or asymptomatic disease being passed on even, and how we need to really understand what public health messages need to be communicated to help people be aware of this, take decisions to seek treatment, and of course take measures in people's activities that can prevent it being spread.
And what about vaccines? Is that going to be the answer to trying to prevent spread?
Absolutely. So Mpox is not a dissimilar virus than smallpox. So even the smallpox vaccine could be helpful. They obviously stopped smallpox vaccination in that region many, many years ago. But even the smallpox vaccine that we know is safe for works, that potentially could be safe and easy to use as an immediate question whether we could mobilise something very quickly. But there are Mpox vaccines being developed, and this is the good news. So we are, ahead of the curve already with this. So we need to get those into this region with 1B. That's the important point, because there are vaccines being mobilised across Africa, but this 1B outbreak is in very distinct areas at the moment, and so we need to mobilise the vaccine to those regions, and we need to test it in those populations, and then look at strategies of how we could prevent transmission and limit disease by getting these vaccines developed and tested as quickly as possible.
Now, when you say it reminds you of the early days of HIV, I mean, that sounds alarming. What do you think the future looks like with this? How worrying is it? Is this something we're going to see spread around the world, or could that be prevented?
Yeah, I think there's two important sides to this. That it is worrying, and it's obviously a highly contagious and very devastating disease. We're obviously in the early days of this still. I think if it could, of course, people could easily get onto a plane, and it could travel to Europe and elsewhere, and that's really a strong likelihood at this point, I think. With the advances we've got in vaccines and everything that we could mobilise, I think it could be quite well contained quite readily if it spread to Europe and the wider world. And we're watching and ready, and I hope things can mobilise very quickly, especially vaccine testing and implementation. What actually really worries me, is just why I think the analogy with HIV is really useful, is I don't think it's quite as cheerful picture potentially in some of the really difficult to reach places in Africa, where HIV still is a huge burden and a disease of poverty. And even in this area we're working, many people don't know their HIV status. So HIV is still a massive burden even in this region. And in fact, it could be quite an important factor. What we're looking to see as well, as if people are already infected with HIV or indeed TB are more susceptible in this disease, and if that's making people more vulnerable to this infection. So what concerns me is it's because of the sexual transmission and the close contact and the disease of poverty, it can spread in the same way HIV did along these truck routes, mining towns. Really vulnerable people in these communities are the young sex workers that are exploited, mothers we're really seeing some worrying outcomes in pregnancy that are really serious and we really need to understand. And so there is this congenital transmission. We are seeing babies infected. And so from my experience of working in HIV and other diseases of poverty like malaria and TB, I do really feel concerned for the equity and the response that we need. So I think it's quite likely it's going to appear in Europe and elsewhere, and I'm sure the world will mobilise quite quickly to tackle that, but I wouldn't like it to be an inequitable response in Africa so that it doesn't become the huge burden that it's looking like it could be.
Yeah, so is your hope that we learn in a way, that the world learns from these past epidemics that we've seen? We know what happens.
Well, yes, look, Claudia, we just said before we spoke, didn't we, that you and I meet at these times with these conversations, and I think this is the worrying point, that have we learned? You and I have spoken during Ebola and Zika and, of course, COVID, but the lack of equity in these responses is often is quite disheartening, and we should learn, and maybe from COVID at least we've learned that if we do mobilise to look after these regions, it does benefit the whole world, because in fact we really were able to mobilise with this 1B outbreak because the team was already in this region working on other infections and in fact trying to build a research capability response. I was in Rwanda with the team because we were looking to build this research capacity strengthening network, and the team talked about this emerging infection they were seeing and how different it was. And so because we were putting those skills in place, they were able to respond, and they noticed this was different. This research is being led by these remarkable young researchers in this region because we've been able to put the skills in place to support them, and they can react quite quickly. So this is the sort of piece we need to learn, and I hope COVID has taught the world that we need to have these research capabilities and brilliant young researchers trained across Africa and elsewhere who are working all the time on whatever is the disease in front of them. It might be cholera, malaria, TB, but they're working in their communities to look at the diseases that affect them every day. And if we have those skills in place, then those same practitioners are able to say, look, this is different, I'm seeing something I'm worried about, and they can mobilise the international response that's needed and lead it from their country. So that's really what I've been focusing on the last few years, and I hope that if COVID's left some good, it's the ability for funders and governments to understand that kind of need to have this capability in place all the time, so we haven't got to helicopter it in from overseas.
Yeah, very well made point there. There are various vaccines being developed, though, aren't there?
Yes, there are. There are Mpox vaccines that are licensed, but there's many more and slightly different technologies in the pipeline. And so what would be really excellent is that this evaluation of these vaccines is accelerated, but really importantly, in areas where we are seeing clade 1B as the prominent variant of Mpox, because we need to know those vaccines work just as well on 1B, and also, of course, test them at scale to see if they're safe. So that would be a really important next step.